So can we go ahead with the second presentation, please, Dr. Swaraj?
Our second presentation is FUNDAL COLOBOMA, an ode to the variety by Dr. Sony Sinha. She could not make it. Pratik will be helping us out. His son, Dr. Pratik, her son, sorry.
So the presentation basically is by Dr. Sony Sinha only. It's a recorded.
Full volume for this presentation. So good morning, ladies and gentlemen. Thank you, esteemed chair. And let us begin. Full volume, please. Okay.
The audio is from there.
Retinochoroidal colobomas, an ode to the variety. There are no financial interests. RC colobomas occur in 0.5 to 2.4 per 10,000 live births, either in isolation or with systemic anomalies with varying phenotype. The embryonic fissure starts developing at the 4th week of gestation and closing at the 6th week from the equator. It gets completed at the 7th. The retina splits at the inner nuclear layer or the autoplexiform layer. The inner layers continue to form a thinned out intercalary membrane, where the outer layers curl up to fuse back with the RPE. The junction is called locus minoris resistentiae. The choroid terminates peripheral to the point of reversal, while the sclera is thinned and ectatic. OCT may show the transition zone as abrupt or gradual. The intracalary membrane may have cystic spaces, schisis or breaks. Vitreous attachment at the margin may be present with condensation. Intercalary membrane may also show hill-like projections into the vitreous cavity. Subclinical retinal detachments and eye intercalary membrane detachments can also be found. The colobomas may be either typical or atypical, complete or incomplete, or formifrosty or extreme with a cystic eye. The Eiderman classification is according to the extent and location of the coloboma, while the Lingam-Gopal classification takes into account the location of the disc, whether outside or within the coloboma, and the morphology of the disc, normal, abnormal, or independently colobomatous. These are some of the colobomas found in our institution. They may be associated with a number of genetic varieties and syndromes, which may be autosomal dominant, recessive, or both. It may be associated with hedgehog genes, PAX6 genes, PAX2 genes, PTPN11 gene, CHS10, or CHD7 gene. Any part of the body may be affected, including the brain, head, face, ears, neck, thorax, abdomen, skin, limbs, and the endocrine system. Secondary colobomas may be the result of drug intake by the mother due to nutritional deficiencies and other causes. The ocular associations may be in the lid and the lashes, the size of the eyeball, and can also be associated with axial myopia, cataract, motility problems, nystagmus, squint, leukocoria, glaucoma, and a non-detectable scotopic ERG. Associations may be bilateral or asymmetric. Amblyopia can occur due to refractive error, cataract, squint, dysphobia, dysgenesis, or other complications like lens dislocation. Rhegmatogenous RD has been related in 8% children who are less than 10 years old. It can occur in up to 40% eyes with RC coloboma. CNV may need anti-VEGF injection. Studies have shown that recurrent retinal detachment can occur in 53% of eyes. 39% of eyes have been shown to have a visual impairment of less than 20 by 400 visual acuity. Other studies shown colobomas to be 70% bilateral, 20% familiar, 3% in blind school children, 10% amongst patients attending a visual disability clinic, and 10% patients for visual handicap certification. Microcornea types 1 and 2 and intraoperative complications have been associated with poorer visual outcome. The RP Center has taken to apply 3 rows of contiguous laser spots of 400 microns in diameter at the margin outside the arcades, and have found that only in 2 patients out of 323 eyes who underwent prophylactic laser developed dermatogenous retinal detachment. So the take-home message is the features of coloboma vary from minimal anatomic evidence to cystic eye formation with commensurate variability in visual function. The extent may vary and the involvement of disc and fovea may also be variable. An awareness of the types and associations helps in prognostication and timely management of problems associated with this condition. Thank you.
I have one query. So if a child is born with FUNDAL coloboma, we can make out. So what is the earliest age the child should have laser?
Can we have the answer from one of the panelists who is a retina person, Dr. Santosh Mahapatra?
You can, if it is a already macula involving coloboma, there is no need for
Meanwhile, I'll
laser.
request Dr. Sunil Sunana to take a chair on the please.
If
Please,
it is a
please, no,
macula
it's a
involving
protocol
coloboma, there is no need for laser.
There.
You just need to observe it. But if it is a
No, no, no,
macula
yeah,
sparing
part of it.
coloboma, you can do laser as soon as possible when the child becomes eligible to take general anesthesia.
Is there any so much urgency that infant should be put under anesthesia and then
You should not be in a hurry. At least you can wait for a year also. I can give
Yeah,
it.
Dr. Kashyap, he wants to add something.
We have been doing tackling this kind of a coloboma since long, and I named as a anchoring laser way back in 1994. So we have a vast experience of this. What I feel that the moment you see that is the case of a coloboma, you have to understand whether the macula is involved or not involved. You have to do the laser as early as possible, because the kids are prone for trauma and all that, and the patient can develop retinal detachment after trivial trauma. If the if you are doing the anchoring laser, you are surrounding all this coloboma with the laser, you have to be you have to make sure that it do not reach the macular arcade. Number 3, if you have not, we have a study also. If you have not done the laser in the posterior pole near the macula, the incidence of retinal detachment is much less. But when a periphery has to be, it has to be included in the laser.
Yeah, thank you. Thank
This
you,
is very
Pradeep.
important.
Thank you, Dr.
Thank-
Vibhu.
I'll just have one.
Thank you, Dr.
I
Pillai.
think, sir, I fully agree with Kashyap, sir. I think it's as early as possible it should be, whether
Yeah.
it is involved or
Sir,
not, because
take home-
handling a detachment is a much more
So
tragic thing to
take home message is that it should be taken up as early as possible. Right, thank you so much.
Thank you,
Yeah.
Dr. Vibhu and Dr. Kashyap,